Welcome, everyone. I'm Sam Shen, Vice Chair of Clinical Operations at Stanford Department of Emergency Medicine. I'll be moderating today's exciting session on emergency medicine and healthcare administration and leadership as an avenue for career development. We've got a very distinguished panel of healthcare leaders at the school and hospital system level that excited to share their experience and perspective on healthcare leadership and administration, again, in the perspective of career development. With that, I will turn over to have each of the panelists introduce themselves and speak a little bit about their experience. Thank you.
Hi, good afternoon. Thanks so much for joining us late in the afternoon. My name is Nancy Kwan. I'm the Vice Chair of Emergency Medicine at the Long Island Jewish Medical Center at Northwell Health, and an Associate Professor of Emergency Medicine at the Zucker School of Medicine at Hofstra and Northwell. Just to give you a little bit of background, what we're going to do, the format is each of the panelists is going to talk about our own journey into healthcare leadership. And then we'll have plenty of time for Q&A, and we'll be monitoring the chat as well. This is in part sponsored by the SAM Faculty Development Committee as well. And this is probably the third or fourth time that we've done this didactic before. So a little bit about myself. I currently, as the vice chair, that wasn't always my role. I came to Northwell Health in 2013. Prior to that, between 1999 and 2013, I was at Bellevue Hospital Center at NYU, where I was, I had some administrative roles. I did some research and academics, but I didn't have a leadership role there per se. It was in 2013 that I had a great opportunity, and that was one of my coworkers, former coworkers at Bellevue, Sal Pardo, reached out to me and said, would you be interested in an associate chair position at Long Island Jewish Medical Center? So, out of a lot of interest, and also feeling, at that point being a mid-level faculty member, I wanted to explore that opportunity, even though I felt very comfortable in my shoes at Bellevue, NYU. So I went to go visit, had a really good feel of the place, and knew that it was somebody that I knew well from beforehand. And then interviewed, came back a second and third look, because I am one of those people that in order to make a big change like that, I really would have to feel it, and know that it was the right thing for me and get a feel of the people. And after multiple visits, I did get the right feel for it. So I came on as an associate chair of academics and research at that time in 2013. And over the course of a few years, at that time, there was a lot of transitions that were happening at Long Island Jewish. I really didn't have any sort of leadership training or background other than, being a frontline physician at Bellevue NYU, but a lot of it was sort of training on the boots on the ground, and there was so much work to be done there. So I started off as that. Actually, there were some transitions within our department, mostly because people, some of my coworkers, which include Dr. Salvador, that you'll hear from shortly, were promoted. So then I also became the associate chair of quality, performance improvement and quality. And then most recently in 2019, I became the vice chair, and the vice chair role at LIJ is really more operational. But I still enjoy doing a lot of academics and some research as well, and try to balance those two, which we can talk about later, which is oftentimes a difficult balance. So it's been a really rewarding experience, and I think lessons learned we could talk about later in the Q&A session. So I'm gonna pass it on to Dr. Nicole Franks to introduce herself and tell us a little bit about her journey.
Good afternoon, everyone. Thank you for joining us today. So I am currently the Chief Quality Officer at Emory University Hospital Midtown. And I am an associate professor of emergency medicine, and as of 1 week ago was confirmed to be a professor. So my promotion was confirmed. So yay, that does happen in these roles. So want to make sure to encourage that. But so when I came out of residency in 2002, I had always aspired to be a hospital leader. And I didn't really know what that meant, what kind of leader. I just very much enjoyed the environment of the hospital, and which was part of my attraction to emergency medicine. And at that time, there was probably about 5 maybe fellowship programs in existence, but they were all in places that I was not ready to move to. And so I stayed at Emory and came on faculty. And actually, I tell people I did a bootleg fellowship. So the old-fashioned way, when you actually just show up and you find you have a mentor, you show up. And so very fortunate to have Leon Haley as a mentor at the time, who was the chief of emergency medicine at Grady Hospital within the Emory system. And so that's where I kind of learned my way. And he gave me lots of opportunities to be successful and to fail, all of which I learned a lot from. And that really put me on a pathway for the next available positions, which happened to be assistant medical director in the current hospital that I work at now. And during that time, I spent about a total of maybe 7 years or so in the emergency department in a medical director role, and really moved into a lot of the problem solving and quality improvement efforts that were going on in the development of the Office of Quality at Emory. Gave lots of opportunities for learning about quality, about lean management. And so getting involved and getting face time within a lot of those efforts really is where I developed a lot of my skills that put me in the running for my current position of Chief Quality Officer. And I'm happy to talk more about what that role is, but that's really been my journey as far as being a hospital leader. And it's absolutely the right type of role for me, and I think an optimal role for an emergency physician, because as a Chief Quality Officer, you really have a hand in a lot of things, and you work with everyone, and it's really something that we are groomed to do as emergency physicians. So I'm looking forward to our conversation, and I will hand it off to Eric.
Thank you so much. Good afternoon or evening, everyone. My name is Eric Cruzen. I've been with Northwell Health pretty much my entire career. I started pretty much right out of residency as a staff ER doctor, and then quickly moved into an associate director role. And this was at a moderately sized community hospital in our system. And I worked there for about a year, and then there was a big IT initiative to switch from paper to a fully automated system in the ED. And I was happy enough to be able to lead that initiative. So that's sort of my first foray into healthcare IT, very enlightening. I continued at that hospital for another 8 years, worked up through assistant and associate director, really started doing mostly operations and department operations. And then 2014, I was selected to be the founding chairperson of New York City's first freestanding emergency department, where I was chair for 6 years until recently. And meantime, I have a couple other hats as well. Over the last 6 years, I've had the role of Chief Medical Informatics Officer for Emergency Medicine. Our health system is 23 hospitals with 19 EDs on 3 separate EMRs and with a bunch of other IT systems as well. And so in my role, I sort of serve as the human interface between all of those different systems, all of the people that use those systems, and all of the IT people in the background that make it happen. So I always joke that I'm trilingual. I speak business, medicine, and nerd. So it's a handy role. And then most recently, my third hat is that I've started a new division at our company called Integrated Solutions. It's a new attempt at creating a division that's made up of IT folks, medical folks, and web designers and architects. And we're creating new innovative applications to solve clinical and business problems for the health system. Lots of different things, which I can elaborate on later if anyone's interested, but essentially we're using real-time data feeds from all of our various systems to drive web apps that actually can be used by folks at the front line to help prioritize their task lists or know what the most important next thing to do is, allow leaders at our department level to see how their operations are running in real time, and a variety of other things. So it's pretty exciting. So all my mother told me about my misspent youth with computer games was wrong. It was actually handy after all. So with that, I will hand it off to Dr. Terry Kowalenko.
Hi, I'm Terry Kowalenko. I am professor and chair of the Department of Emergency Medicine at the Medical University of South Carolina. I also currently serve as the vice chief of the acute care trauma service line. My path to leadership looks a little like an individual with ADD, to be quite honest. Because I came out of residency thinking I was going to be a research scientist. I was doing basic science research, and I thought that was going to be my path. For a variety of reasons, things changed a little bit, and I ended up as an assistant program director at Henry Ford, and then was asked to serve as program director at Wayne State University at their Sign of Grace program. I did that for several years, then went to University of Michigan to be their program director. I was later promoted to the dean's office, where I was the director of continuous professional development within the dean's office. I thought the dean's office was going to be my pathway to the rest of my career, but an opportunity arose for it to be a system chair for the Beaumont Health System in Michigan. And so I ended up getting that job and was chairman there with a new medical school and 3 emergency departments, and with about 100 faculty and 280,000 visits. It was an awesome job. Within 18 months, I was asked to serve as president of the Beaumont Medical Group, which is about 550 docs at that time. And then about a year later, they combined with 2 other hospital systems that had 2 other medical groups. And I was asked to serve as the president of the then combined medical group, which was close to 1,000 physicians. I did that for several years, and then moved to the position I have now, as I mentioned before, as chair at MUSC. The other path that I think a lot of the leaders you're going to talk to today also take is, I mean, that's sort of the paid path. Those are your jobs, but almost every single one of us has also had many other roles within our organizations, like SAM. And so I held many subcommittee chair and chair positions for committees, and was eventually on the board of directors for the Michigan College of Emergency Physicians and became the president. I then was elected later to the board of the American Board of Emergency Medicine, and eventually served as president of the American Board of Emergency Medicine, and currently serve on the executive committee of the American Association of Academic Chairs of Emergency Medicine, the Association of Academic Chairs of Emergency Medicine. I suppose as one who's on the executive committee, I don't know the name. But that's my path, and I'll pass it over to Judd.
All right, thanks, guys. So I think, for the audience, what I'm hearing, and we've gotten together, the panelists, before and chatted, I'm hearing a theme of evolution. So Sam recently indulged me when I was in California, and we played some tennis together. So I'm going to start with one of my first non-medical jobs. I was driving home from college at Albany looking for a summer job. I played college tennis and was reasonably competitive back in the day. And one of the pros who I took lessons from when I was 12 was working at a club in Syosset or Woodbury, Long Island, for the Long Island crew here. And so I turned into the club to go in and get a job. I was at the wrong club, and I left that job as the assistant camp director for their tennis camp for the day. And that's sort of been my evolution, is I have never gotten a job that was advertised that I applied for. Never. Every one I applied for, I got turned down. I came out of residency and I didn't apply for a research director job. I just did research until I was obviously the research director, and then they made me that. Then I moved from Stony Brook to Penn. where they had a new residency. They weren't looking for a research director, but I convinced them it's a good thing. And they hired me to do that. And I ran a clinical research program. And, I did all the stuff where you're supposed to write a 10-year plan and figure out what you want to do. And my 10-year plan and path was to be a chair. And it's actually brilliant. Ted Christopher, who is my current chair, just buzzed in. And so I did my 10-year plan to be a chair, applied for a couple chair positions, and along with the theme, didn't get it. And the whole time my wife was telling me, you don't want to be a chair. You want to develop cool new programs. And that used to be what a chair was 20 years ago. Right now, a chair is managing what senior level leadership tells them. And I went in when I did my chair interviews and said, I want to grow urgent care centers. I want to grow a telemedicine program. I want to do a bunch of cool new stuff. And the best thing that ever happened to me is I was turned down for those positions. And through conversations with Ted Christopher and others at Jefferson, it turns out Jefferson had a new CEO, and I met with the dean and the new CEO, and they gave me this job that nobody really knew what it was. Originally, I moved over there as an associate dean of strategic health initiatives. Nobody knew where that was on the org chart, what that reports to, what that does, but that was the majority of my time. It evolved into, hey, Judd, can you start a telemedicine program and grow out the urgent care centers, which was really much more like a senior vice president role, and ultimately morphed into adding that title. And so my day-to-day activities are largely outside of emergency medicine, but Ted Christopher is my boss within the emergency department, and I still have a pretty good presence there. But it once again evolved to jobs that didn't exist. And jokingly, the number two at the time at Jefferson, in introducing me to people, says, I don't know what Judd's title is. He could have made it up on his own. And I reminded him that he let me make up my title when we negotiated contracts. So it really was. Now, along the line, what made that work isn't just that I showed up. I prepared myself not for a job, but by developing a skill set. So I went back to Wharton and took classes, didn't get an MBA, but that got the skills. I did a year sabbatical with a bunch of guys that owned a chain of urgent care centers. So they didn't give me a job I didn't know how to do, but I developed the skills rather than get a degree, rather than apply for a job, that someone rolled the dice with me and gave me a chance to do something that was new and different. And I think I will turn it over to Annabella.
Great, thank you. Good evening, everyone. It's a pleasure to be here. And I guess my story is similar to many that you've already heard. I can relate to Terry being ADHD, and I can definitely relate to Judd about never really applying for a job that I have received. So I serve as the Senior Vice President and Associate Chief Medical Officer for Northwell Health, which is New York's largest healthcare system, and we're also the largest employer in New York, nonprofit employer in New York. And as Eric mentioned, we have 23 facilities, over 800 ambulatory sites, and we are about 78,000 team members strong. So it's a pretty large system in the Northeast area. And so people often ask me, what does medical affairs actually mean and what do they do? So just to give you a quick highlight, I deal with essentially credentialing, privileging, hospital bylaws, physician and allied health professional issues, things like suspensions, terminations. I am the lucky one that reports to the Office of Professional Medical Conduct in New York when any of our physicians have to be reported. We also report to the National Practitioner Data Bank whenever there's reporting required. My other role, as I believe Terry said, we often have many roles. So my other role as Associate Chief Medical Officer is working on standardizations across the system, especially as they relate to our system P&T, and also anything, well, nowadays it's anything related to COVID. I serve as one of the co-chairs of our clinical advisory group. And also I serve as a chair of our system policy and procedure committee. So standardization is definitely one of my roles. And then the last role is Associate Professor of Emergency Medicine at our Zucker School of Medicine. And, I've been with Northwell. It was actually my first job since residency, and this was before we were really a system. I worked at North Shore University Hospital, was my first job, and I worked as a staff member there, and eventually climbed through the system into the role that I have now. I never imagined a career outside of emergency medicine. I loved emergency medicine. Initially, I loved working with the residents. I thought of being a program director. But then at the time, my chair and vice chair asked me if I would do quality. And so after doing some months of quality, they said, okay, you're now the director of quality for the emergency department. And then in that role, I also liked operations because quality liked to fix things. And I liked, fixing things and improving efficiencies and lean projects. And so that led me into operations, which then there was a job at LIJ where Nancy works, and they asked me to also be one of the associate chairs along with Nancy at LIJ, Long Island Jewish Medical Center. So I became the associate chair in the emergency department. And from there, I got to work with a lot of other departments and with hospital administration. So hospital administration had asked me if I would consider going into hospital administration. I did not have any background in hospital administration work, but I decided to take a chance. I said, how bad could it be? We work in the emergency department. We can handle anything. It's probably going to be the same thing, just at a bigger level. So I became the associate medical director. And then from there, I moved into the vice president role for medical affairs, and then now to the senior vice president role. And people often ask me, well, what's the role, like? Is it difficult? And I say, it's the same thing we did in the emergency room, just a little bit bigger. But if, these types of roles are great for emergency medicine physicians, I think, because we have the skills that it takes to, one, deal with different departments. We know how to do conflict resolution because we're putting out fires constantly. We know how to negotiate. We're always negotiating with other services to take the patient. We're always dealing with physicians that have issues because nobody usually likes to come to the ER to admit patients. So, we're always dealing with somebody who's upset. So I think emergency medicine really gives you the backbone for a lot of these positions, even outside of emergency medicine. And we've seen that in our system. And so we've actually promoted several emergency medicine physicians in senior leadership roles, and we've made them medical directors or positions like Eric and like myself because of those skill sets. So I guess I'll hand it back to Nancy or the moderator, but I'm sure we're going to be talking more on the Q&A session. So thank you.
Thank you, everybody. That was great. And everybody stuck to the time, which is awesome. I'm actually going to challenge everybody to put on their cameras because this is not a huge group, so that we can make it more interactive. And then Michelle, if you could unmute everybody so that, instead of going through the chat, we'll make it more interactive in terms of having a discussion. So I wanted to open up to the group to see, you've heard everybody's backgrounds, if you had any questions or comments that you wanted to make.
I'll start off. I actually have a question for the group. I actually have quite a few, but I want the audience to obviously have the chance to ask. But I'll start off by just asking, because when I hear all your stories, it's very clear that every one of you kind of advanced and took on bigger and more responsibilities. And some of it was, like you said, it was not intentional. It's not like you necessarily apply for a job, but clearly you had success at one level, and success then breeds further success. And people noticed that you were successful in what you were doing, and whatever that means, so that you can then take on more responsibilities. Even if that role wasn't necessarily something that your background necessarily would have put you into, or you had even prior experience. I was just curious. I want to put out to the group, what does it mean to be successful at that initial level? And then as you keep progressing up, what does that what does success mean for folks who are trying to embark on this career when they think about, wow, I want to advance. And so what do I need to do to make myself apparent that I am succeeding in whatever I'm doing? So I'd love to kind of hear from your perspective, what does that mean to be successful in that first or second position that then allowed you to then take on the third and fourth position and then continue to be successful? What does that look like?
Yeah, I'll be happy to go first and see if people have a different opinion. But I know what I want to see. I want, just like when you're writing a manuscript, just like when you're writing a grant, just like when you're doing anything else, I want people that are solving my needs. Terry will chuckle when I say this. I don't want somebody who walks into my office and says, I want to be the left eyeball specialist. Give me 2 hours. I want someone who knows everything about the left eyeball and never asks for time or money and just does the work. So I think it's like, you know, 90% of it is being present. It's show up, be present, solve the problems that are important for the institution, not the things you want to do. And people will go to you. And at the same time, be present and say yes. Because we were chatting about this before we went live on the air here. You ask somebody to do something and they say no because they put up their boundaries so they could have wellness and more life at home. That's great. They got more wellness and more life at home. But I want somebody who's going to do the work at work to move up. So you do need to, in yourself, decide on your own wellness, but it's solve the institution's problems and people notice you're the go-to person.
Yeah, I'll jump in. So one of my other hats is I am a co-fellowship director for emergency medicine administration. And one of the things that I emphasize to my fellows is that you have to deliver. You know, it's about finishing, because if you can't finish and then tell, it's finishing something and then being able to tell the story about how you got there, gets you there as well. So you don't always have to get it right the first time or in the shortest amount of time, but you do have to finish, and you do have to be able to speak to what you learned and what are you going to do better the next time. So those are skills that you really need to make sure that you have and you leverage. I can't echo enough that we say show up, but you also want to make sure that you are getting in front of the right people. So if you are delivering on something, who are you telling? Who are you letting know that you're doing it? So if you're working on something, step up to those opportunities to present in front of this group or this leadership. Because when people see you representing a deliverable, then they say, hey, I know her, she's always doing this, or I know him, he's always doing that. And so your name goes into I hate to tell you, this is how it works. It goes on a list and people remember, right? So, you know, those are just really important pearls that I will say, because I mean, I've gotten on lists, and that's how I've progressed. And a lot of us here have the running theme of being tapped to do things. And so that's a big deal, to be tapped to do things. And so be mindful of what you're taking on. There is a way to take on more and balance what you're doing and still be well. So, you know, that in and of itself is a skill of a leader. So, and it can be accomplished. So I just want to encourage everyone as we talk through these things, that those things can be done. And there's everybody's formula or recipe for doing that, just like managing hypertension might be a little different. Just saying, to be effective.
I'll also add in that on a personal level, to me, success is measured by, I think, mentoring and coaching as well. If I can teach somebody to do my job well, and I could leave the organization and that department is running efficiently, then that to me is successful, that I was able to, you know, help somebody else get to that position. You know, to me, I always feel like it's about mentoring and helping others to also be successful. You know, I always get nervous when somebody says, oh, this person is leaving, and that whole area says, oh, it's going to fall apart. That person wasn't a good leader because they didn't plan and help, you know, others to succeed so that there could be a smooth transition. So you always got to think of, you know, we call it too deep. Think of, you know, 2 layers of succession planning. That should be one of the first things you start thinking about right away when you're taking on a new role. Is yes, you want to be successful, but how am I going to plan for, you know, if I take on a different role, and unfortunately in our health system, sometimes a role may only last a year and they move in you already to another position. So you have to start that mentoring and coaching early on.
And I'd want to just dovetail onto some of that is that, and I know Judd, you mentioned about that Terry would probably agree with me, and I'm sure that Ted will agree with me as well, is that just coming into the chair's office and asking for a position doesn't usually work. I make it very clear to my faculty that I want them to develop, but I want to have some clear goals, timelines, and deliverables. And when people step up and do things, even before they have protected time to do the job, they are the first in line to get the protected time when it does become available.
Can I add, just think Shark Tank. You ever watch Shark Tank on TV? It's a great show. You invest in, you know, when these sharks are investing in companies, they're investing in the person based on their demonstrated ability in the past, as much as they're investing in the product. The same thing is in grants. They review the investigator. So the key is to, you know, to Sam's original question and Terry's comments, is be the person people want to invest in.
See, Dr. McKenzie, did you want to say something? Sorry, like, go on. How about other questions from the group?
Guys, I had a question. I guess this is more so for the general audience as well. First of all, thank you for the panelists for offering your time here today. It's really helpful. I'm a second-year resident at Cincinnati, thinking about operations and administration and getting more involved at a resident level. What tips or advice you guys have for someone at my stage of training to help me start thinking about this moving forward, so that when I potentially apply for a fellowship or look for a job out of residency, that will help show my future employer that I'm someone who's going to be able to be a good candidate for that position?
So I would say, find a project to work on and as best you can complete it or complete some part of it. A lot of that is also any opportunity that you have to shadow leaders. So it's going beyond just sitting and talking to people about what they do. Actually ask if you can go to a meeting with them and see how they work. I think is always insightful as well. So getting involved in something early as a resident is something I look at favorably as a fellowship director, because you're demonstrating your interest, even before coming into training. So that's what I would advise.
I agree.
Yeah, we actually had embedded in our emergency medicine residency rotation where they spent a month with administration, emergency medicine administration, and they would come with us to meetings and to committees, and we would give them projects to work on. And it was amazing the feedback that we received, because a lot of times residents would say, I never knew you guys actually did all this work, and a lot of, information goes into this. And they were shocked at the amount of work that sometimes administrators do.
Yeah, I couldn't agree more to follow folks and to get involved, because until you do that, you almost have to be in the other person's shoes a little bit to understand what they're doing, because you may find shockingly that you're not as interested, or that it really is the path that you want to take. So I think getting involved early is critical, so that you can be, whether it's doing a fellowship or it's doing some advanced degree, because I think early, when people ask me about advice about advanced degrees, I tell them, I wish I had gotten one when I was younger. I'm now too far along to get the return on investment, so to speak. And frankly, I don't know how much I would actually learn that I haven't already learned on the job, so to speak. And so I think that all the advice you've just been given is very good.
Yeah, I'm going to add to it a little, just to sort of change the edges around what Nicole said in being out front and center. It's really important that you're not out in front and center until you've performed. there are at my institution lots of med students who get significant time with our hospital leadership to tail them around. And they have the connections, but they can't walk the walk. That's not going to get you ahead. You get ahead by walking the walk. And so I think at the beginning, it's find your group of people, have your nose to the grindstone, produce, and then get the, the appropriate rewards for what you've done. And that pathway, I think, is really important. At the end, your work product lives. That's what matters most.
If I can add to what Judge just said, he said, so one of my friends is the CEO of Snowflake. And I was having dinner with him a few months ago, and he kind of said the same thing that Judge just said. He said, I don't care what kind of degree you have or where you received that degree. What have you done? What have you accomplished? That's the most important thing to him. And he's a PhD in business. And he said, it's not about the degrees. It's not about, like I said, where you got it. It's what have you done and how have you performed? And so if it's true in the business world, I can assure you that's true in medicine as well.
And Terry, I'm just going to add to that, because leadership to me is it's not about your degree, and it's not even about a position. It's more about you as an individual and the behaviors and the skills you have, because you can be a leader as a chief resident. You could be a leader as a frontline emergency medicine physician who has to lead that team that night during the shift. So there's, it's really on how you define leadership. And to me, leadership is at all different levels. It's really not about positions or degrees, or I got an MBA, or I got a master's of public health. It's really about what you do day to day. At least for me, that's.
And I have to add on to that and agree that, you can have, I think we've probably seen examples of people who have titles, and are supposed to be leaders, but truly are not leaders, and people who don't have titles who are leaders. And, I think, I don't know if you're the only resident in this group here, but, I think it says a lot that you're here at SAM. And I think you were on another meeting with me before the faculty development meeting, so I think you're already very involved. And, in reality, people who work enough with their residents really have an idea of who is going to be somebody they want to bring on, pretty early on in your careers as a resident versus somebody who, doesn't show those leadership qualities. And to Annabella's point, like, anybody can be a leader without a title.
Just so I'm not the only one who didn't contribute to that question, I would say everything you've heard is correct, but I would also say to keep an open mind. All of the best opportunities that have happened in my life have come out of left field. None of them were, much like you heard from everyone else, none of them were jobs I went and applied for, and several were things I hadn't even considered on my radar. But I was just doing the things that I did, I got on committees that were interesting to me. When something bothered me at work, I tried to fix it instead of complain about it. And that's just my personality, but that got me interesting invitations to things that then turned into jobs. But you'll often do the job you're going to do for a long time for no money, and then eventually you'll get a title that goes with the job that you've been doing for a long time on the deal.
I think Dr. Slovis had a question. Is that right?
I do, if that's okay. I don't want to change the topic. So I'm going to take the opportunity here to ask a question that's very specific to my career, but conveniently there seems to be people, at least one person on this, who can answer the question. I apologize for commandeering the conversation. But so I'm a junior faculty member, and I'm a board certified informaticist, and I have an interest in pursuing informatics and hospital level informatics positions, whether that be associate or CMIO or something of that nature. And I'm curious from the people on the panel who have hospital level positions, and those that have informatics positions, their thoughts on emergency medicine positions in informatics. It seems like many other administrative and operational roles, we are perfect for the job in the way our job works, but we also have a very focused view of the hospital, and I feel that sometimes that's a shortcoming. So I'm curious what your thoughts are.
Start with that one. I have absolutely no professional training in IT whatsoever. Everything that I know about IT, I have picked up along the way, or I learned from programming my own video games or doing web development that I did for fun and stuff like that. So I just found out that there's actually a board certification in clinical informatics a month ago, and I applied so I can take the boards the last year that there's a practice pathway. So I hope to join you there. I think emergency physicians are extremely well qualified to do just about anything, and that may be a biased view. And while we do have a narrow focus, I think we are the best problem solvers in the hospital. I think Annabella said that a little earlier, is yeah, we may focus on our little niche, but if a problem arises elsewhere, we know how to debug it. We know how to work through the frustrations that those people are probably having. And right now, a lot of clinical informatics is about new stuff. It's not about, fixing the EMR that's horrifically broken that is never going to be fixed. It's about building new tools that go around it, above it, or that add whole new dimensions of functionality on top of what we already have now. So.
Yeah, I just want to throw in that informatics is, a frontier that hits everybody's bottom line. We have an ER physician at our Grady Hospital is the CMIO. I would say that quality leaders are very much involved in some of the informatics development, because often some of the problem solving requires a system solution, especially if it relates to practice. And it's involved, everybody always wants an IT solution. So there's lots of ways to show up for that. And what I would say, and it's the same advice I think I gave earlier, is get on a committee, get some face time, finish a project, have some deliverable, get out there, and then that will not only show and demonstrate that you have this solid interest in getting there, but also will give you street credibility as well as experience in the path that you want to get to. So, and don't close yourself off. I'm just saying quality is one way to get in the game, but operations, really medical school evaluation, there's all kinds of avenues. And ER physicians should never sell themselves short in terms of just because you only live in the basement of the building. Trust me, you should leave the basement. That is something we could all do a little bit better, but because we tend to only want to be in our own environment, but you'd be surprised how much you really can translate your experiences in anywhere. And you already know how to talk everybody else's language. So you really don't have to worry about that fit in aspect of the job. You'll be just fine.
I want to just dovetail onto that, because I think that's a critical component of this, is don't sell yourself short as an emergency physician thinking that you're in some relatively small niche. Because when I was president of nearly 1,000 physician medical group with multi-specialties, my understanding of their specialties was far greater than their understanding of each other's specialties, because we interact with every single one of them. I mean, there's not a single specialty in the hospital that we don't interact with and know how to speak their language, as Nicole just said, is that when you're giving a report to an internist, it's going to be a very different report than you're giving to a urologist or to general surgery. So don't sell yourself short. You actually have, I think, a greater breadth of knowledge of other people's worlds than they do of each other's or of ours.
Thank you. I think I saw Dr. Hope hand up.
Yeah, I was getting a nice little run in, so I don't want to keep my nice listen to you guys all talk while I get a little bit of workout in. So I'll keep the camera off for that reason. So I'm a second-year resident at Henry Ford, and I am interested in operations as well. And I kind of have a two-parter. So one of them is I see some areas for operational improvements and kind of the balance between research, formalized IRB versus making that tweak, where you do the project to show that you have a tangible output with the before and after intervention. And then I guess the second part that kind of stems off and actually piggybacks off the previous informatics question was a lot of my questions or kind of ideas are based on retrospective sort of pulling out from the EMR with some data grabs that I don't have the capabilities or background with, and just curious avenues or people in the hospital or resources you'd recommend for reaching out to for help with projects like that.
So can I refocus your question? And I don't mean to pick on you. I know you're a resident, but you're directly contradicting with at least my philosophy. I think it's wonderful that you have the initiative, but you're doing things you want to do and you're not solving other people's problem the way you just described it. So when I had a big research career before I moved into what I'm doing, I didn't do asthma. I didn't want a student coming to me with an asthma project. I didn't know anything about asthma. I wanted to build careers. Otherwise, if I was teaching people how to do research, it was in my area of research, so they could add to what I knew and I could better mentor them. But I wasn't going to learn a whole other area to help mentor them. So I think the first question you have to ask yourself, as you're not, and it might be too early to know the answer, because maybe it's operations, maybe it's research. Where do you want your career to go? Who do you want to mentor you? And then if you want to see what operations is about, then do what's important to your operations team and do research they care about, because then they'll jump in and really help you. But if you walk in and you want to know if blue toenails are not going to room 42 for some reason, nobody's going to care about that. I know that's a silly example, but if you have something that helps with ED boarding, wow, everybody's going to want to work with you on that. So I don't want to denigrate what you're saying in any way, shape, or form, but I think your best chance to learn how to do the things is to partner with people who are interested in it, not to say I have what I call a one-off project and say who's going to help me do that. Because in this day and age where budgets are super tight and everybody is stressed, and no one has free time, it's unlikely Eric's going to stay late to do a data pool for somebody that's never done research and isn't entirely clear how that's going to happen. Eric, you could tell me whether I'm wrong, but it's all about alignment.
Yes.
Don't do them. I only
That
teach
is
people how to do them. you need that. Your question actually, and I'm sorry, Nicole, to step on that.
No.
Your question is great. The answer is you should figure out how to do it. If you want data, you should figure out how to get it. And it's not going to be handed to you, and it's not going to be necessarily something that you'll just ask one person and they're going to show you. You have to find the people that are interested in teaching how to get your data. And as a researcher, you will be infinitely more valuable if you can get your own data than having to rely on people like me to produce it for you when we feel like it. Sorry, Nicole.
Yeah, that's an interesting data question. I get asked about data, and I leverage it as an opportunity to say, now exactly what problem are you trying to solve? Because I really think a lot of people ask for data and they want to look at things, and half the time they don't even use it because they don't really know what they want, and they don't really know what their problem is, or if it really is a problem. It's, but so I think it's always an important conversation to work through. Tell me why that's bothering you. Tell me how you know that's a problem. Let's get there. And often I get, well, I need the data. Well, let's ask. You can get data a lot of different ways. You can just ask 5 people, and that's data. So we have to work on that. But I just want to emphasize the alignment piece again, because if you can hook into that, and that's really just a strategy. That is a strategic skill. Because you can advocate for what you want to get done, but you got to hook it onto something if it's not its own already standalone objective. So if you really want to do asthma, then with Judd, you got to find, well, how does asthma, impact heart disease, or whatever Judd's thing is, right? And so that's how you have to approach it. So it's just, you have to learn how to strategize and make your objective work with everyone else's.
Thank you all. Appreciate it.
What was your project, by the way, Dr. Holbrook? Just out of curiosity.
I hope it wasn't asthma.
No, it wasn't one in general necessarily. Just as I've kind of been in talks today, a couple of the admin and operations talks were interesting, and kind of some of the factors that they analyzed and such. And I was just, I was like, oh, that would have been a project cool to take back, kind of implement, but I don't even know where the first place to begin to review some of those data points would be. So it was just kind of a reflection based on some of the talks that I was in on today, not necessarily a specific talk.
Right, what I tell you is just go watch the process with a clipboard and a piece of paper and collect your data, and you can see what's happening. And then you'll learn what questions you need to ask and what data you need to ask for and how to move forward. And then you'll find out who to ask.
Sounds good. Thanks again.
And I
Great
also
talk.
think here that you know, to everybody else's point, that mentorship is really important. So if you know, you're sort of stuck in where, you know, which direction you go, like in a place like Henry Ford, which I think is pretty big, right? There's probably a lot of people that may be interested in this project and have importance in it. And to everybody else's point as well, with regards to data, I think they want to make sure before, you know, not all data is that easily achievable. So, you know, in all transparency, Eric Cruzen is the person I'll go to if I need a data pull that I can't do. And he's actually set up a lot of dashboards that we can pull our own data, which is great. But some of the data, you know, I do need some extra help with, but it is time consuming. So you don't want to ask somebody to pull data for you if it's not something that's important, you know, for something, whether it's for operations or to answer a research question, without a well-formulated question, because nobody wants to pull data and then find out, well, you're not going to use it anyway, or it wasn't that important of a question.
Yeah, and with the ability to pull, you know, millions of different observations, having a very well formulated question before you actually dig into the data will save you a ton of time. You know, if you want to study asthma, you don't say, pull me the charts on every asthmatic. You know, you say, I think these are the 10 observations that are going to be important in my study about asthmatic. Let's pull a small subset of that and let's see if that's true. And if it is, then we'll get bigger.
Hey, y'all.
Bye.
Thank you, everybody, for joining.